Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from India, Dr. Sharan Srinivasan. Dr. Srinivasan is the HOD of Neurosciences, Bhagwan Mahavir Jain Hospital, Bangalore, and he's also the CMD of PRS Neurosciences and Mechatronics Research Institute. His research and clinical interests are focused upon neuromodulation and neurorehabilitation, and he has won several awards for his contributions towards these restorative neurosciences. We are extremely grateful to him for accepting our invitation to be a speaker for our webinars, and today he'll be talking about functional neurosciences is the future. The speaker for the second session of today is our honored guest from China, Professor Kiao Zhou. Professor Zhou is an associate professor and assistant director of the Neurovascular Center at the Shanghai Hospital, Naval Medical University, Shanghai, China. He is an expert in the field of interventional cerebrovascular surgery, and he has won several awards and honors for his academic and research work in his country. We are extremely honored to have him today at our webinars, and today we'll be talking about stent treatment for acute ruptured aneurysms. The chair for the first session of today is a distinguished faculty from India, Professor Krishna Kumar. Professor Krishna Kumar is the professor and head of Department of Neurosurgery at the Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, Kerala. Professor Krishna Kumar is an expert in the field of functional neurosciences and spine surgery. He has published several papers in this regard, and we are extremely grateful to him for accepting our invitation to chair the session of Professor Srinivasan. The chair for the second session of today's webinar is our honored guest from Japan, Professor Yoichi Morofuji. So Professor Morofuji is an associate professor in the Department of Neurosurgery at the Nagasaki University School of Medicine, Nagasaki, Japan. He is an expert in the field of neuroendovascular surgery, and he has published several articles in various peer-reviewed journals, and he is also an associate editor for the journal Clinical Neurology and Neurosurgery. We are extremely grateful to him for accepting our invitation to chair the session of Professor Kiao. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Krishna Kumar.
Thank you, Dr. Raja, and a warm welcome to all the participants as well as the people who are joining online from all over the globe. Greetings from the southernmost part of India, Kerala, Trivandrum, where the monsoon is at its peak, and I think it's a happy time that we discuss something which functional neurosurgery can do to our part of the world. And as one speaks about functional neurosurgery, several things come to our mind, including the surgery for movement disorders, the neuromodulation side of it, stimulation, ablation, the various surgeries for epilepsy, surgeries for spasticity, stereotactic radiosurgery, and very innovative peripheral nerve surgeries. And of late, management of pain is also coming as play a major role in this part. And several innovations and technological advances have happened so that the level of care which is given to the patient who is otherwise unable to perform even his activities of daily living is now almost like sort of cured. That kind of level of care is achievable in many of the patients who are worked up well. So this involves three major steps. One is meticulous patient selection, meticulous selection of the method in which the patient is treated through, and the most important is the post-procedure or the post-programming or the post-functional neurosurgical follow-up. So I think considering all these three regards, I think we have the best person here in this part of the world, Professor Sharan Srinivasan, who is the most sought after speaker in most of our functional neurosurgery sessions. And I don't want to waste more time. Over to you, Professor Sharan, for your deliberations on what the future holds in store in the arena of functional neurosurgery.
Okay, so good evening to everybody. Thank you, Professor Krishna Kumar, for a warm welcome, and greetings to my co-panelists and hosts from the Silicon Valley of India, which is Bangalore City. So I'm going to talk to you, like I said, the Silicon Valley of India. I'm going to talk to you about a very interesting science with the Professor Krishna Kumar said, but I want to start very quickly with what the conventional neurosurgery or the neurosurgeon is doing. People like me, when we start our practice, I was to always tell people I'm in the hardware business. I'm going to use a lot of smartphone and computer language, which is very different from what it is. Because honestly, when I talk everywhere, I tell people I come from the original IT industry, which is the central nervous system. Everything else is a pale copy of that. A lot of people are trying to copy what we're doing. So I think it's a very apt way of relating to what's going on. The hardware business of neurosurgery, all of us are familiar with a symbol like this, a clot in the brain, and it needs to be operated. You do this, the clot is dissolved. The question is it operation successful? Of course, because there's no clot on the scan. The question is, what about the patient condition? Most of them think if the moment to operation is successful, patient should be fine. That's not necessary, because we have all realized very early in our practice that physical healing is not necessarily equal to a good functional outcome. And that's the biggest problem. The ideal goal for all of us that we want is to restore back 100% of the pre-morbid level of functioning of every single patient that we operate or that we treat. But the question is that possible in every patient? The truth is no. The mental shift that I had to make from being predominantly a structural neurosurgeon, removing pre or post-op scan, tumor, no tumor, hematoma, no hematoma, to a functional neurosurgeon was quite dramatic. And it had a lasting impact on the way I even evaluated and treated all my patients, both emergencies and electives, whether with brain or spinal cord issues. So that brings me the topic of the day, which is functional neurosciences. And I think this is the future. Why am I saying it so emphatically? It involves a unique word of neuromodulation with advanced neurorehabilitation. And it's the magic of treating hardware and software together. The only organ in the body which has customized software is the human central nervous system, and we have neglected that like no other. And those patients of ours who are dependent, our promise is from dependence to independence. It's a journey of hope and possibility. If you look at all of us, whether whichever part of the globe we are in, whether the rich or poor, male or female, doesn't matter the race, region, religion, whether in the case of emergencies or cases with deficits, everybody's question is, will my patient improve? Will she become normal again? How long will it take? What all do we need to do? And is there hope? Meaning, is the patient rehabable or recoverable from the process? In case of electives or cases without deficits, their anxious questions are, will she develop new deficits? Will she become normal like before surgery? How long will it take? How do we minimize this risk? And how do we maximize the results of rehab, if at all? To answer these questions, we all need to know, as medical professionals and neuroscientists, what was the reason for the situation of the patient? Was it the stroke, head injury, brain infection, spinal cord problems, degenerative diseases, brain tumors, whatever? What's the current level of functioning of the patient? Is absolutely normal. That itself is debatable because normal is so varied normal, for all of us. There's no normal brain function test, unlike all the other organ functions. What are the current different disabilities that the patient is having currently that's stopping them from functioning well? What are the expectations of the family or the patient? Is it realistic and all that be achieved? Do we know all the abilities the patient needs to have to have this outcome? How do we know if the patient is improving, progressing? Can we measure progress? How can this be communicated to the family? Can we issue reports? So much is happening and so little is known in this space. And I think there's so much of work to do. This is the last frontier, I feel. And why am I saying this is a burning problem, at least in a country like India, is a new epidemic is emerging. I'm quite sure many countries are battling this in their own size and shape. It's called neurologic disability. It's going to join the other public health concerns as the third epidemic, leaving the pandemics that we had recently. And there was a study done by one of our national institutes called NIMHANS. This is in 2010. And they said that just three things: an increase in traumatic brain injuries because of road traffic accidents, age-related dementia, and an increase in stroke incidence in India is adding technically so many, at least 16 lakh neurologically disabled people with dementia, stroke, and this is the impact. Together of just these three conditions, leaving the brain tumors, the HIEs, the neuroinfections, the Parkinson's, degenerative process, and everything else, just these three, head injury, stroke, and dementia. In 2010, the studies showed that we're adding more than 35 lakh people or 3.5 million people to the disabled population annually. And this is people, most of them being in the prime working age or the productive citizens of this country. and all those equivalent to large cities of moderate cities of India, the 2022 statistics are much worse. If we add all the other patients who develop disability, like I said, for various other neurological causes, iatrogenic or otherwise, these numbers will only get bigger and nastier. So the question is, it has a negative impact of India's demographic dividend. So we're going to have more and more people who are disabled. They will not die. So let me start with the world of neuromodulation first. My guru in neuromodulation, is Professor Takao Mitara from Tokyo Women's Medical University, Japan. I'm quite sure all of us are exposed to all these words. Some of them, some of us use it, but most of us hear it around us. VR, AR, MR, robotics, AI, ML, DL. The truth is, guys, we all as neurosurgeons and neuroscientists come from a world called real reality, which is RR. And let's look at some effective misbehaving brain circuits, some of the work that I have done, a surgery for focal hand dystonia, the musician's guitarist dystonia. I did a VO thalamotomy. He was a 39-year-old gentleman with a well-played guitar. You can see his...
These two have become so stiff, I cannot bring it on the fretboard. I can't. God, it has become so stiff. I cannot move at all. Can you see? I'm trying, but I cannot.
And then usual stuff, fully awake surgery, playing the guitar during surgery. Obviously, I learned this from my guru in Japan. Nothing original from my side. So that's what happened. And as we are taking real-time feedback, the fingers, as you can see, is dramatically better as we lesion the circuits in the brain. He also had difficulty typing. Left hand, you can see the fingers curling. Right side, you can see him typing very well. Real-time feedback during surgery. And this is the lesion, 9 centimeters inside the brain in the VO nucleus of the thalamus. This is him. That with his fingers. The results last. That's the question everybody asks. Is this temporary? And it keeps improving. As you can see, his finger movements are continuing to improve. The dexterity of the fingers is just amazing. How much is possible with followed-up rehabilitation along with the surgery that has done. Another patient who had a multitask dystonia, like Professor Krishna Kumar said, the diagnosis is the most important thing, because most of these things are clinical diagnosis. You need to have a good movement disorder neurologist with you who's willing to make the right diagnosis. And obviously, the medical line of treatment should have failed, and then we go through this. He came in from Bangladesh. He had, very clumsy. He was a professional guitarist, actually, and he was very clumsy at the end of the day. Very clumsy. He could not make a C movement with his left hand. But otherwise, no weakness at the end of the day. And he couldn't text. Right hand is fine. Left hand is not okay. If you see, the thumb flexes. He's not able to see. He's having difficulty. Even holding the mobile phone is very, very, dangerous. He's not able to flip a coin with his left hand. He couldn't put a hand in his pocket and pick up a coin from his pocket to give. He's not able to do it with his right hand. So you see so many tasks that he had. It's just amazing how many of us can see these patients in OPD, and sometimes we can listen to the busy practice. And this is him during surgery, checking all the tasks that is done. And we can see on table that there's already improvement in what's going on, and we continue to improve, and this is him, lesion there. And you can see on the Excel frame, the usual, dimensions that we had. 3 tracks, 6 lesions. 3 in the center, 2 anterior, 7 lesions, 2 anterior and 2 posterior. And that's a large lesion in the ventrolaris oralis nucleus of the thalamus. Those are the lesions that we can see. Like Professor Taira, I do a pre-op and post-op MRI with a stereotactic frame on, so that to make sure that every time we have got the target that we ended out wanting to do. These are the 2 guitarists playing together. So they did well. 3 months after the surgery, this man climbed a 7,000 meter Himalayan mountain, showing how safe these surgeries are and how good they can be with no neurological deficit. He was an avid mountaineer. And this is him 9 months after surgery. You can see how fast his hands are moving compared to the previous one, and see how, so you can see the fine movements that he's doing. It's incredible what's possible. Writer's cramp, same here, thalamotomy. This guy is struggling to write. Look at the way he's holding the pen, the strain that he's having, the speed that he's doing. Now I'll show you, this is the 3 handwritings. The left-hand side was his original handwriting 2 years before the writer's cramp. The middle one was about a month before surgery. And the last one on the right is just the day before surgery. He could only write half a page. But this is him after surgery, immediately after post-op, about a month. You can see he's comfortably writing, though he's a little slow. He's relearning to write well. And if I show you his handwriting now, you know, it's whether it's with a ballpoint pen, a gel pen, plain paper, lined paper, it just doesn't matter. It is that much better. And you see how comfortably he's holding. The discomfort in the hand is gone. And this is what is possible. All these are functional outcomes that patients are looking for. Now we go to VIM. This is a post-traumatic tremor, post-head injury. This is what he had. He had the problem here. You see him trying to drink the bottle. You can see how difficult it is on the left-hand side. And in the middle, these are Holmes, tremors, something like that. It's very difficult to get 100% results because of the scarring the thalamus, but he's done reasonably well. That's him, and a year after surgery, still able to manage reasonably well. At least he's able to manipulate the bottle and survive by it. He's a little anxious because of the camera that is shooting him. Otherwise, the family says is much better than this. Again, the lesion of the VIM nucleus of the thalamus. This was a very bad case. A young adult who had a severe head injury at the age of 9 years. He had this movement disorders for 17 years before he saw me. Right upper limb. Extremely
Place it back on the table.
severe tremor. You could ride a bike, you could drive, you can wear a shoe, you can hold anything in the right hand with that severe. And that's him just before surgery.
That's nice. We hope in the next 2 hours this will stop, Travis.
This is in post-op day 2. He had a last scar in the VIM nucleus of thalamus, so had to actually mute the lesion just around it. He developed a minimal right lower limb drag post-op. Once in a while still bothers him, but he's about 60% better. He's able to manage himself. He's able to tie his own shoelace, pick up things. In some positions, he gets a tremor, which is not as vigorous. In some other positions, he's fine. He's driving a car, riding a bike, attempting to ride. He's doing well. So you can see him, he's able to work the bottle, he's able to start writing. Writing is not so much that he does, so but he can manage himself and do the activities. A patient with tremor predominant Parkinson's disease. This lady, one side ipsilateral tremor predominant, not much of bradykinesia. 7 years, no benefit with symptom. That was the problem. Very severe tremor. So any tremor, both upper limb, lower limb. This is what we did. Same lesion, VIM thalamotomy. You can watch the there. Tremors dramatically stop. That guy in the front is my movement is a neurologist. He's there with me at every surgery. She's fine. Post-op, there's no tremors. It's been about 4 or 5 years since we did this. There's absolutely no tremors. So this is the somatotropy. All of us know that somatotropy extends right from the motor cortex all the way down. This is the somatotropy of the VIM. So we have to be very clear, not just about any area of the VIM. We have to be careful which parts of the body is having tremor, face, tongue, upper limb, shoulder, lower limb, foot, leg. Based on that, we have to make sure the appropriate areas are covered. Now, this guy is a 53-year-old male. He had double-confronted dyskinesia. The middle video is off. The first one is when middle is on, left is off. This will be the levodopa challenge test. And you can see him post-op. I did one side. We wanted the left side to be fixed. And then again, I'm comparing on, off, and post-op. So all 3 are going on at the same time. There's significant level of dyskinesia. And you can see he's really frozen in the off stage. And that's him now, like this. You can see the post-op, all the movements are happening well. That's him, pre-op off, pre-op on, post-op day 2, and 1 year after surgery. He has no on-off fluctuations. He has no level of person induced dyskinesia. He's still on drugs. He's been on materials in surgery. It is very, very happy. It took some time for his confused body to get better because one side is operated, one side had mild symptoms. Over time, he optimized medicines and he was doing fine. So the question right now, I'm just showing you many surgeries just to show what is possible in a resource constrained setup like ours, where DBS is impossible to do in every patient. People can't afford it. People are from far away. They cannot come back for a follow-up. They cannot come back for programming. So it's extremely difficult. And, the government doesn't fund it like Japan. I keep telling my professor that. So all of them have to pay out of pocket. Insurances don't get covered so much because these costs are very high. So her handwriting improved dramatically. She could not even sign. Handwriting improved. She had, the speed got better. So the tremors went away, and that's how she was. So he also had labyrinthitis dyskinesia. The dyskinesia have gone.
Right.
And I'll show you just her. This is her about 6 months after surgery. So it's just amazing what both of those people underwent a pallidotomy, GPI, this cervical dystonia, one side, torticollis, lateral collis. He had this for 7 years.
I was not able to see like this and watch. I cannot see your mobile because I can see, but like this, like this.
Usually in pallidotomies,
Is 4 months.
it takes sometimes up to 3 to 6 months for the complete result to see, unlike a thalamotomy. So that's what it is. So the question I'm going to ask all of you is bilateral lesion. So the common argument we have with people who do DBS surgery is, lesioning is only done one side. You can't do both sides. Too risky, dysphagia, dysarthria. So the question is bilateral lesioning surgeries. Is that really possible? Is it safe? Can it be done? How are the results? So I'm the only man actually doing bilateral stage lesions in India. This is a bilateral stage lesioning for Parkinson's disease. One side we do pallidotomy, other side we do PTT, or pallidothalamic tractotomy. This is a PD case. Classical mixed type, left more than right. You can see that. The classical features of PD. Radicals here, visually, aspects, walking. So a lot of the problems are getting out of the house. This is him 18 months after the one side pallidotomy, right side to fix his left side tremors. On the left side symptoms, you can see how much better he's already. Left hand, right hand tremors, left hand no tremors, right hand tremors, left hand no tremors. The gait is already much better. He pushed me for surgery during the pandemic, between the second and third waves. This is in 1 month after the second surgery.
Bilateral lesioning surgery for
In
Parkinson's.
fact, stop sit up for 24 hours,
Right side
just see
pallidotomy,
what's going
1.5
on.
years later.
He was a tailor, he went back to tailoring. He put both the upper limb and lower limb, coordination. It's just amazing what's possible. Very poor guy. This is him walking. This is how he is about a year after the second surgery. On the left-hand side, he works in the hospital part-time as a patient coordinator. So even in anxious situations, so there's no tremors, there's no anxiety, there's no work without any problem. See that. He's taking care of people. Okay, he's doing well. So simultaneous bilateral pallidotomy, I had to do this in a complex movement disorder with a failed DBS. He had undergone a bilateral GPI DBS. For some strange reason, he had not developed symptoms. He had not developed result of symptoms. You can see how severe it is. The left-hand side is a video of a patient with the DBS working at home. He still has extremely lot of symptoms. His father somebody has to still hold the head. Only then he can get up. It's a multisegmental dystonia. The head still falls back. He walks like this. The right side is, the video. Without that, just watch the right-hand side video. This is the DBS before removal. The DBS had gone dead. This is how bad he was. The family didn't have money to replace the battery because it was they felt it was the hadn't worked very well. So I pulled out the battery so you can watch him trying to drink water here. Even if the father holding the hand, this is how severe the symptoms are. He's not just not able to do his routine activities of daily living. He's not able to even leave his hand. The bottle is stuck to his hand. You see the father hold it for him to leave. Just use his left hand to pick up the pick up the bottle.
Sir.
No, sir.
Because this was so severe, I had to give him GA to fix the frame. So under GA, we had to wake him up during the lesioning to make sure we have the target right. So it was a very stressful situation, but did what we did. Bilateral lesions, the left one, the right side symptoms are more. So I did a larger lesion on the left-hand side, a smaller lesion on the right-hand side, simultaneous at the same time. You can see the two lesions there, 3 tracks on the left-hand side, 2 tracks on the right-hand side. Second day post-op, it's even before we started rehab, the retrocollis has come down significantly, he's able to sit by himself. We still have a lot of, also a lot of cellular signs. And then with organized rehab,
विदाउट झुके हुए 1 मिनट तक खड़े रहना आपको.
was so happy. So sorry, I'll show you.
ಸ್ವಲ್ಪ
This is some of the result that we got. We have second month.
सावकाश.
So we have
अभी
very
वापस आओ.
important such complicated
लेफ्ट साइड
cases.
वापस आओ.
Look at him trying to drink the bottle of water. He couldn't breathe at all. You saw it pre-op. Post-op is able to reach out very well. No strain, no tremor, no dystonic movement.
Right kay munde perfect.
Leave it with the right hand, pick up with the left hand, so you can see. He still has a lot of cerebral signs. There was a lot of cerebral atrophy on the scan, which is a part of some degenerative process. Yeah, but 70% better. He still has those neck pulls frequently, but he's able to manage himself. He goes to the fields, he uses the bathroom himself. His ADL is independent. He's able to go and supervise the workers. So the mother doesn't have to be with him all the time. He needs some support like this. This is 5 years after surgery. So the family feels that even though he has this problem, he's still able to manage much better than what he was earlier. So that's why. So we'll move track from all the lesioning surgeries for various movement disorders to intrathecal baclofen in TBI and SCI. Spasticity, all of us know, is a bugbear for all neurologists, neurosurgeons, rehab professionals across the world. Intrathecal baclofen is being well recognized as a treatment for severe disabling spasticity, whether cerebral palsy, stroke, spinal cord, brain injuries, and apart from spasticity, also central pain it reduces. Is now a standard of treatment. He's a 19-year-old boy, met with a severe road traffic accident in 2020 March. He had emergency treatment. He was in ICU for more than 70 days, tracheostomized, underwent a PEG. He had received 1,200 units of Botox because he had severe generalized spasticity, oral doses of pacitane, baclofen. He was in GCS-17 when I received him for rehab about 3.5 months post-surgery. He had decerebral posturing on and off, and severe spasticity, restricted neck movements, flexor contractures, distal more than proximal, bilateral hands, tendinoacles, further improvement. He was very, very bad. So we were thinking, so what do we do here? When you have a combination of contractures, deformity, and spasticity that you cannot distinguish one from the other, what do we do before pump implantation? We need to know if the pump will help. So in our institute, we do something called examination and anesthesia. That's the first step. We give GA, the rehab team comes into the theater and assesses every joint, every movement, the range of movement, spasticity, and see how much of it is actually spasticity induced, how much of it is fixed because of tightness, contractures, deformity. So we have data about that. This is him when during the trial. We give a catheter in the back at whatever level we want and infuse baclofen at with an infusion pump for 5 days. Similar to what the pump will work, when we implant it. So that's what we did. And some people wake up. Like I said, the decision, first step is examination anesthesia. Second one is to do the trial, which is implanting a catheter inside. I don't give only a start dose of baclofen. I leave a epidural catheter in the subarachnoid space. Depending on which area, like this boy needed, result even in his neck muscles. So I left the tip at around D2, D3, and then make sure that, head on was slightly elevated so that there was no, respiratory problems. This is the examination and anesthesia. It's going on by a rehab team. And then we started this one. He woke up. We have a detailed way. We have an Excel sheet that tracks all these things. It's pre-programmed. He keeps telling us what is the modified Ashworth score and how the score is changing. Every 2 hours, we check it and keep titrating the doses based on the modified Ashworth score. This is how much it gets better. Very evidence-based done, very meticulously done. And that's why we get the result. He woke up 15 days after the pump was implanted. Left side started improving. He still had. This was the bonus. So Professor Tara used to tell us that some people do wake up. You still see on the right-hand side video, his hand was posturing. He's reached a stage to play chess right now. He does his own therapy. His right side is still having a lot of contracture deformity. But if you see his texting, which I will show you, he's celebrating his own birthday. He's cutting his own cake. That level of manipulation is got. You can see him changing channels on the remote. The fine motor skills, you saw how his hand was to various come. He's able to manage himself, at least when he's sitting on the wheelchair. Fine motor skills in the left hand. Speech is still difficult to understand, but his content is good. So if you see his WhatsApp text, I think somewhere I missed putting it. No grammar mistakes. Cognitively, he's doing very well. We have a way of actually scoring. We have our brain function test, which I will show you, which is able to tell us how he progressed, what is happening. Next, guys, is Asia A, an incomplete D7, D8 level. He had this passivity. I think I'm going to skip this. This is usual stuff. I don't want to do this. I want to show you more of this. D5, D6, demyelination, transverse myelitis. He was plegic, placid. He recovered after acute treatment by our neurologist. He had severe spasticity. Oral baclofen didn't work. And before baclofen, he was a driver profession. He had a lot of trouble. So much.
Left फिर से उठाइए. Left leg ऊपर. हाँ, very good. Right उठाइए.
Just not
right.
Better.
नहीं, right.
Now he's reached the stage 2 years after the pump. They will drive his car.
Yes.
He's able to sit down. Well, he's able to sit down. The right hand side video we can see. This is an amazing thing. India sitting down. Is one of the very important things that we look for. And he's able to sit down and get up by himself without support. So this is a very interesting video. Just watch this video. The pump became empty during the first lockdown. We couldn't get the medicine. And there was a lot of shortage. So you see, he's got a spontaneous clonus in both his legs. He came for a refill. Finally, we got the medicines, but you can see severe clonus in both legs. So, that's how severe it was. So you can see that right more than left. And you can see the second video, which is just 3 minutes after refill. 90 minutes, 90% of the clonus is gone. Just with 3 minutes of the small dose that is gone. You should keep asking me, Doc, am I still dependent on the pump? Do I need the pump? Can I get down? He had reached about 394 micrograms for 24 hours. Now he has improved so much that we have come down to about 150 right now, and he's doing quite well. So we'll move now to another place called, time is being quantified. All of us know this data about how many neurons get lost in one circuit. So brain function test, all of us know this renal function test, liver function test, heart function test, pulmonary function test. Is it really possible? Is it practical? Can we mass customize it? We have attempted to do that in our own system. I hold a patent for this. This is a global patent, a novel and robust curriculum for advanced neuro rehab, which has part of the functions. This is in French and India in English, which is a global patent that is there. We have also, this is the World Intellectual Property Organization has done 184 countries. We have crossed that link. We have applied for an American patent for this in the year 2022. This is a second patent, a system and methodology for assessment, prognostication, and tracking recovery of damaged functional brain circuits for predicting functional independence. This has been applied in 2022, both in India and globally. And we built a software based on this process, and we won a national bio-entrepreneurship competition. For this software, it is the largest bio-entrepreneurship competition in our country. 3,000 plus startup companies from across India took part in this, and we won the prize. So like, do we really see with our eyes, hear with our ears, smell with our nose, talk with our mouth? I've always been fascinated by this brain circuit of, the eye going all the way to the back. The VA is the visual association areas, PA is the posterior association areas or the sensory, multisensory association areas. The A is the anterior association area or the frontal association area, which is the decision making for motor, functioning to happen. The hardware, software, we know about that. What's the hardware? The central nervous system structurally looks more or less the same for all of us if you look at the MRI. But the question is the software. We have all of this. So what's your brain's operating system? I asked all my people, is it the same for every one of us? Is it iOS? Is it, Android? Who gives it to us? Who gives it for us to download? What happens if we don't do it? So we have our own software called Neurologics. The Neurologics is a smart neuro rehab concept, which is specialized measurable methodologies. We have assessments, analytics, and AI. R is rehab, and T is techniques and technologies. These are routine life inside the house, life outside the house. I'm showing all this. I'm not going technical because this is what our patients ask us. Technical is there everywhere. We have a concept called C2C, especially in patients of stroke and head injury and spinal cord problems. C2C for brain is called coma to community in brain injury rehabilitation, and C2C for SCIR is called COT to community in spinal cord and neuromuscular injury rehabilitation. Our concept of C2C is translated to Phil, life inside the house, life outside the house. Now, we are based on the care ray principle, which is clinical, anatomical, radiological, etiological, and rehab. This has been trademarked, this care ray principle. So what is it? It's the progress and prognosis prediction, function restoring tools. So how do we do that? We have the SAFER test and the rehabability index, which is called the brain function test. And this is on our website called rebootingthebrain.com. All of you can go and actually look at it. And rehab operating system is called the brain rebooting protocols, and together it's called the Neurologics. And then it's based on the science, which is, like I said, the care framework, clinical, anatomical, and everything else, the novelty. So what do we do in neuro rehabilitation? Starting with waking up the unconscious brain coma stimulation to physical rehab, to occupational therapy rehab, neuropsychology, cognition, speech, language, dysphagia, swallow, nutrition, cognition, behavior, and vocational rehab, VR, AR based. So brain injury rehab, all of you would have stories like this. Patients who did 2.5 months into this, not even eye contact, right? He's like this young guy, young student, after 7 months.
Hello, doctors. Thank you so much for healing me.
So what I want to show you now, do you think he's still normal? Not yet. He's like the FM radio. It's 94.3 versus 94.5. The actual channel is 94.3. You'll hear music plus noise. What am I trying to communicate? It's like how we keep checking the blood sugars, the blood pressures, the ECGs regularly. We do not have any such tests or any such data in neuroscience for us to check whether the patient is actually normal. Just because he looks okay, he walks into our outpatient or he's doing some function, it doesn't mean the underlying circuits, especially the cognition software, is firing well. So unless every of these circuits are checked meticulously, nobody can know. It's like, the smartphone, you have the WhatsApp, you have the Facebook, you have the SMS, you have your bank app. Everything is an app in the brain. The brushing is an app in the brain. Eating is an app in the brain. Using the texting is an app in the brain. Each of these circuits have to be tested, and only then we will know how close it is. Because many patients come and tell us, I'm not feeling okay. I'm not able to get back to work. I'm not able to drive. I'm not able to think well. And because we don't know, we say, oh, you look okay. That's all it is, and things like that. We've got some great results. Again, like I said, if we did not have GRBS and GCS and RBS to measure unconsciousness, how would we measure patients? If CT MRI was not able, then what? So similar way, the C2C concept has helped my system to really establish an evidence-based process of measuring patients' brain dysfunction and spinal cord and neuromuscular dysfunction. So that as we are treating patients surgically, medically, pharmacologically, with neuromodulation and neuro rehab, we know the patient's progress and know what's going on. Another lady, severe TBI, decompression clinic to be done. She was very bad. She was in outpatient sensation for a long, long time. In between, she started waking up, and then she slowly got better. But it took us 6-7 months. We can promise patients here, because, like I repeat again, in India, everybody pays out of pocket. I'm quite sure in many of the countries it's like this. Before we write out the patients, is it possible for us to show the families what's going on. This girl slowly got better. She had bilateral hemiparesis. From that, she got better. She still had problems in speaking. And then over time,
Oh.
she still, you see, she's right.
वापस करियो.
The voice is still not there. 6 months of rehab. And then the ADL training. Each of these things she had forgotten. We had to retrain her how to eat, how to brush. Meticulously done. This is her back at home after 8 months in Mumbai. And then, you see that she went through this whole process. This is she still has some a foot drop because of lower limb injury, but she has done much better. She has done a course in social media marketing. She's doing some online job right now. She's on the move while she walks, but she's extremely independent. All I'm trying to show you with all these videos, I'll skip all these things. Because she was in TikTok. So
अब मुझे जाना होगा.
प्लीज थोड़ी देर और रुक जाओ ना.
तुम समझती क्यों नहीं अगर मैं यहाँ रुका तो
क्या?
तो वहाँ भंडारा खत्म हो जाएगा.
So she's gone back even into leisure activity, which is such a joy for the family to see. 15 months after the head injury and rehabilitation, she was a young student. And this is the original lady before the accident. So from coma to cooking, this lady had intercerebral hematoma. Again, her brother came and asked me, is it worth operating? Is it worth doing these things? But, she had bilateral EVD split, she had infection, she had bilateral hemiparesis. She took about 3 months to wake up. She had IVH. Slowly she woke up after 2 months. The movements got better. And then she's making, those, we call them chapatis, and that's what is happening at home, and that's what is going on. So one of the things I promise people in our center is we can walk without a circumduction gait. Circumduction gait is one of the default modes of recovery after a stroke of people having gait, who haven't done gait training properly. So we're able to promise people that we can walk without a circumduction gait. This man slowly got better. He had better movements in the fingers, and he slowly started getting better. You see, the gait is so much better. And then, he's able to reach this level of even running. So left hand still took some time. So, like I said, one of our major promises is no circumduction gait, but we've only been able to achieve this with those patients who come to us early for rehab before the gait has started. And for those who have already got the circumduction gait, we cannot undo it. So she was Asia C with a cervical dorsal spot spine. And then what happened in the hospital, unfortunately, 10 days after surgery, we had fused her. She fell down from the cot, attempted to get out of bed by herself. She was paraplegic, and she became Asia B. And before we started rehab, she was quite bad. She became plegic. She couldn't even turn to the side. Over time, she got better. Otherwise, she was completely dependent. And it took a long time for her to get better. But like again, I remember she was very depressed. She said, once in my future, will I ever be able to walk again? She was a very active lady. And after 6 months of rehab, she came to the quadruped cane. She was able to walk with that. And then walk without the stick. We trained her, still very unsure. We have what is called a fear of fall program for those people who have this fear of falling. And this is the last video of hers. 20 months later, she has reached the stage. This is very interesting to show how misbehaving brain circuits happen. Just see these videos. He was a banker. He had an HI because of cardiac arrest. They put a pacemaker in the heart. He couldn't even identify his own wife.
Your name is Rita.
I'm not Rita.
Rita, you are Rita. You are Rita.
I'm Shanti.
You are Shanti.
Yes.
You are Rita.
Rita is my
You are Rita.
So what's your name? What is your wife's name? What's your name?
It was confusing name, his name, wife's name. You can see him counting now.
And two.
Where is it?
He's a banker by profession. He's like trying to find the number 2.
No, after 1, 2. 2 is here.
After 1, 2.
After 2?
After 1, 2. After 2, this is
No, after 2, what is there?
What is the number comes after?
What number comes?
3.
Yeah, where is it?
This is 3, no?
This is not 3. This is 4.
4.
Huh.
4.
So after 2 is 3. Show me 3.
After 2 is 3. Okay.
Show me 3.
Where is 3?
23 here. No?
Where is 3?
23 here is 1, 23.
No, I don't want you to show 23. Show me only 3.
Only 3 here?
Yes.
Only 3 is here.
It's there.
No, 1 second.
He's pushing just to show it there
23,
itself.
I think.
I don't want you to show 23. This comes later. Just show me 3.
You want to, 3 here?
Yeah.
3 is here.
Number
He's
3.
walking around.
Number 3 is here.
Not in
Look
May.
down.
Imagine he's having these visual association problems.
21 is there.
No, that's only 2.
No. Then I'm, no.
Go down. See, there is something.
There is 1 here.
See properly.
No.
1 or, no.
Okay, now you see
Can't
here.
1, 2, you're not getting it? Okay.
No. Count means?
Yeah, 1, 2, 3, 4 like that.
1 to 10.
Huh.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Very good. After 10 till 20.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. No, it is 11 or 12 you said. 10 you said, no?
From 10 till 20.
10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
He continues to
So
count.
that's what you said.
From 20 to
1 to 10
25.
is
Next.
20 to 25.
After
1 is 21, 22, 23, 1, 2.
So you see he's writing now 1, 2, 3.
1, 2, 2, 3.
He's writing it
Very good.
perfectly.
4,
Mm.
5.
Mm. No, I think it's correct.
10, 3,
This is fast forwarding for
Four.
a lot of time.
5, 6, 7, 8, 9,
Now you see he's not able to read 10. He's written it himself.
10.
Correct.
This is 9.
Yeah, after 9, you have written 10.
I've written 10.
Correct?
No, actually, I did a mistake, I think.
What mistake? No, I think it's correct.
After 9, this has become wrong, actually. Supposed to be, I was supposed to write 10, no?
He
I
writes
have
10 again.
written 1 plus 1, 0 or something like that. No.
So you see here he's not able to read what he's written. Now you see him counting.
What is 2 plus 2?
2 plus 2.
How much is it?
14.
He's a banker
Okay.
by
2
profession.
plus 2.
2 plus 2 is?
14.
14. 2 minus 2 is?
0 it is.
0. Very good. Excellent. Excellent.
Now you see him counting. Adding.
14. It comes 14.
2 plus 2,
Here,
14.
2, 14 is 14.
Okay.
This
He's a
is
banker.
14. Plus this minus.
No, that's plus.
Plus 2.
2 plus 2.
14 and another 2. 14.
So there are 3 dots here. There are 2 dots here. There's a plus mark, right?
This is a plus mark.
Yeah, this is a plus mark.
Do not identify plus mark.
So I want you to count these and then count these and write the answer.
There are 3.
No, count this.
Keep the dots as a factor anybody.
Yeah, teeny,
Huh.
chari,
Huh.
answer,
That's the answer, right there.
answer.
Punch here, you have to write.
5. That is 5.
Perfect. That's the answer.
That's why I'm saying, why this is there like this? I don't know.
He doesn't know. So I'm just trying to show you now.
There
You
are 2
see him doing
squares
ABC.
here
That's all.
and there are 4
I would
here.
say A, B, C, D.
Yeah.
And mark where is you
Yeah.
have to mark.
There are about 3, whatever. A, B, C, D.
What is that?
A,
Then,
this is A,
very good. Next.
A, then B,
Very good. Next.
C,
Very good. Next.
maybe C, D. This not D, it looks like E.
No. Did you finish D? You haven't finished D yet.
D is here.
Where is D? That is B.
This is B. This is the B.
Yeah, you've already marked.
And this is E.
Yeah.
This is C.
No, that's not C.
This is not C.
That is C.
Uh-huh.
This is C. After C is
This is C actually.
correct. After C,
After C, where is it?
After C, what
After
comes?
C, water. After C,
So you see, so much is happening. He's able to.
what color is your hair?
where?
Sorry?
What is it?
What is the color of your hair?
Hair.
Hmm.
Oh, okay. Fair one only.
No, hair
White.
color.
White.
It is white.
Yeah.
Your hair is white color?
Fair color.
No, your hair. Hair.
Tell me my.
What is white color here? Can you show me?
Uh,
What all is white color?
color.
So he's able to show some things. He
Your
got
name,
better after 4 months.
Yes.
Very good. Is your brother Karthik?
Anyway, so what? So we map this whole thing. How does, fill one functional independence level 1 is inside the bed, 2 is outside the bed, just next to the bed on a chair. Fill 3 is inside the bedroom, bathroom. Fill 4 functional independence inside the home and outside the home. We're just trying to make sense out of it. We have broken that down into more sense in our software, which is FBL is called functional body levels, functional upper limb levels. CVC is called cognition, vision, communication. So fill 1 means all this has to be 1, all this has to be 2, all this 3 has to be 3, 4, 5, and so on and so forth. We are training on basic activities, extended activities. Everybody needs all these things. How do we plan a rehab training? And I'm just going to go to the last for want of time. I just want to show you this, then we'll end. Sorry, I'm just slightly late. So if somebody wants a functional independence level 4, it means all these levels have to be 4. We have made 0 to 7 levels, which is 8 levels of everything. What does FBL 4 mean? It means bed mobility, sitting, standing, walking basic, advanced mobility. These many boxes have to be filled. We have data in each of the boxes, which is in our software. Full upper limb, UA is unaffected, A is affected. We have those proximal upper limb, distal upper limb, affected, unaffected, CVC. In language, we have receptive language, expressive language, articulated speech and voice, and then we have the cognition circuits, model 1 and model 2. So what are the features of the neurologics? We have all these things going on, and which is this, like I was telling you, the SAFER, the PPP, and this whole thing is on a process of software. So this is the whole way that we have mapped the brain circuits into a complete map to make this happen. The red one is the first software. The rest of it is the first patent. The second one is the part of the second patent. So I told you all of that. We have the software for this. You can see how our software loads a new employee. We have a complete ERP software. So, this can be converted to any language, whether it's Japanese, whether it's Chinese, whether it's Arabic, whether it's French, whether the multiple Indian languages. The entire business can be run on this. Patients data can be mapped. I'll show you an example of, look at it, a question of bed mobility. You can see, can she show right side? Can she use without the upper limb? Can she turn prone? It's a bed mobility form. Can she do this? Can she do that? And then, the people can click these answers. Based on these answers clicking, there's a logic that goes on. Based on this logic that's going on, a certain levels get declared. So here, the goals get declared. Based on these goals, a therapist strategy comes in. Is he able to roll? Is not able to roll? Go on, so on, so forth, and go through the process. So that's how it is. We have a rehabilitation index calculator. All these are online. You can calculate it. This is the thing we have. And then we have reports that we give like this, exactly what patient is progressing. As you see, eating, drinking, brushing, combing, toileting, bathing, dressing, where the current patient is, where he has to be for his independence level, what is the progress that is happening. So very objective. We're able to do this. The family and the patient himself understands what's going on. They know how long it's going to take. So it's all possible. None of this is available with the current way that you can measure on MRI or a CT scan or any of the blood tests. So with this, we have added technology. We are building our own thing where we can do the body tracking to know what's the ROM of the body. These are gadgets in process. We are building a smart rehab centers doing these things. So you can track it. You can measure the angles. You can get a report. This is still a gadget in development. You can see what is going on. It's very, very fast and tracks very accurately on the phone with the phone camera. That is being done on a phone camera. You can see this. Sorry, 1 second. So this is the fingers. We're showing how the fingers go, hand movements. We saw the rest of the body. We can see we're not yet able to track all the fingers, but we can track the palm of the hand. And then this is for the weight shift, whether he's putting equal weight on both the feet. So you can see there, you can see it's a pressure control mat with 9 sensors on each foot area, front of the foot, side of the feet, and back of the foot.
The hardware itself.
So based on that, you can see how it lights up. Green is right.
A resting heat map, that is resting balance heat map, that is being generated from this particular placement of the foot and balance. So now I can, and correspondingly,
if something is wrong, you can see that red comes there, so you know you're not putting weight there, and so on. We can exactly know what is going on and do that. And then this is for balance training. This is for the face. For people who have facial exercise to do, you can open the mouth, you can track it. You can show the teeth, open the puff it up. And all this can be stored. So you can see the fingers. We can track it. So we have evidence base. We can see how much it improved, whether with surgery, whether with medication, whether with rehabilitation. We know what's going on. So at the end of the day, my take-home message, only technology will not work. The entire mantra for success is Clinitech. And what am I trying to convey? Functional neuroscience is the last frontier to be explored. The only system with hardware, individual softwares, programs, folders, and files in the human body. Restoring data on a crashed hard disk without any backup information is impossible, but on a smart device is still impossible, but it's possible in the human brain. The journey from either coma to commit or caught to commit is a complex marathon race with no clear finish line. Conclusion, the best results in functional neurosciences is possible only with targeted neuromodulation with customized and intensive neurorehabilitation. Establishing an evidence-based process is critical to ensure progress and prognosis prediction. Patience, perseverance, following up, following through are important virtues. Unless the stakeholders from different industries work together, not together separately, nothing meaningful is possible. Meticulous documentation with machine learning and AI is the key for long-term success and market. Thank you very much. Sorry for the overtime. Over to you. By the way, my last slide, we're having a Nobel Art of Lesioning conference. Professor Taira and his team used to run these conferences in different parts of the world. We have the honor of holding this Nobel Art of Lesioning conference the next year, May 17th, 18th, 19th, 2024. Please mark your dates. This is at the level of Asian level conference. First day, we'll have hands-on workshop with some live surgeries, seminars, and more. Please register now for updates. We are hosting this with the Indian Society of Stereotactic and Functional Neurosurgery. This is going to be held in the city of Bangalore. Thank you very much.
Thank you, Professor Sharan. That was a wonderful deliberation. It's almost like watching a movie filled with videos and very less of slides filled with written material. It's more of
thank you.
That is what is required in functional neurosurgery, because
I think so.
The visual signs, and we keep tracking the movements as well as the visual clues that we get. I think we have a quick question in the chat box. I think we should go for it, so that our attendee has put in a question for you, that it is about case selection for pallidotomy versus DBS in a Parkinson's disease. Which subset will you advise pallidotomy, and which subset will you choose for DBS?
I think that's a great and very important question. So a lot of people say that lesioning surgery is for people who cannot afford DBS or a poor man's alternative. And Professor Tara says the same thing. I also agree with him that it's not necessarily what it is, because we all know many of our PD patients remain unilateral for a long, long time. We have seen that happening for 5 years, 10 years, 15 years. So obviously DBS, some people are doing it. Most people don't do DBS because it's an overkill for one side. So they keep saying, let us see both side symptoms come. So one side symptoms, which is lasting, especially, then the pallidotomy is definitely the treatment of choice, number one. Number two, if it is predominantly tremors, many times Syndopa doesn't respond to tremors on one side, definitely lesioning is a good option that is there. Levodopa, and then the choice between thalamotomy and pallidotomy is based on the levodopa-induced dyskinesia. Please remember one thing, even with pallidotomy, moderate tremors go away. So definitely for somebody who cannot afford a DBS, I recommend you still do a pallidotomy because our targets are different. If this guy has the money, we can still do an ST and DBS later on. So you can buy the time early. So one, unilateral symptoms, definitely lesioning surgery is the treatment of choice. Whether you do a pallidotomy or a thalamotomy depends on the symptoms that he has.
Thank you. And do you see an overplay of non-invasive lesioning coming up in a big way? And will it overtake our conventional burr hole and lesioning?
I know that MRGFUS has, I wouldn't say taken by storm, but definitely is trying to find its own, nudging its own place here. We have one center in Coimbatore, as you know, in India. I'm probably the first neurosurgeon to be trained in MRGFUS in Japan under Professor Taira in 2015, because he was still, trying to evaluate this technique. But what he clearly says is those who do not do invasive lesioning, if they go directly into a non-invasive lesioning, because there's no neurophysiological feedback that we get at the end of the day, each targets are different. 1 millimeter in the basal ganglia is like 1 kilometer. So you can make a big difference. So I really still think that the jury is out whether it will completely replace. Yes, for those who do not want non-invasive lesioning, invasive lesioning, maybe it's an option that we have like Gamma Knife had. But I still feel that with neurophysiological backup, with macro stimulation and getting it, we can be much more accurate, and the size of lesion can also be more predictable.
Absolutely, because accuracy is all that it counts in functional neurosurgery.
Yes.
And very nice of you that you highlighted the most important part, that is rehab, which is one of the most neglected part in our part of the world in a research constrained environment. And with this, I think we can wind up the first session of this very interesting webinar. Over to you, Raja, and the team for taking us to the new direction in the second part of the video. Over to you.
Well, thank you very much. It was indeed a wonderful lecture from Professor Srinivasan. We learned a lot, and unimaginable possibilities that neuromodulation can offer in restorative sciences. Are there any questions from any other panelists? Dr. Liu, would you like to ask something?
Yeah, may I ask a quick question? Prof, based on your experience, do you actually have encountered any evidence to show that DBS does really cause neuromodulation or some sort of slow type of lesioning in the brain? My second question, Professor, when you have weakness during lesioning, what is the troubleshooting that you have? Thank you, Professor.
I think the people say microlesioning happens with chronic DBS, but I myself, I do very less DBS, but so I have not seen it in my own practice. But I have, definitely heard people and saying this. I think it's eventually that's what is happening at the end of the day. Because what I've never understood is, on one side we're ablating and destroying a tissue. On the other side, we are stimulating the same tissue, and you get the same result. And I used to ask Professor the same question: how come extremely opposite things is giving the same clinical result? And it's very strange, and I don't think anybody has the answer so far. So I really do not know beyond this what to do. But second, very important question that you asked. Sorry, I just what was the second question you asked? I'm sorry, I just lost.
If patient develop sudden weakness during lesioning, what's the troubleshooting?
Yes. Yeah, thank you. So one thing is for sure is the macro stimulation is very important to know whether you have how close to the IC, because unfortunately God has designed all the targets very close to the internal capsule, so we have to be extremely careful. So normally what we have seen is 2 to 2.5 volts if of voltage, if the patient is able to tolerate without major side effects, then it's a safe place to lesion. With macro stimulation about 2.5 volts, sometimes you can still get side effects. So sometimes the side effect starts when you stimulate and it goes away if you continuously maintain the stimulation. So that's a good thing to see whether there is that stimulation comes down. And once you have confirmed all of that, and then you lesion, if for example, if I am not sure whether I'm still at the right spot and there's a risk of a damage happening. What we have learned is up to 55 degrees centigrade of temperature, the damage to the brain is reversible. So normally what do I do is I start with a lesion of 50 degrees centigrade to 20 seconds. I see what's going on with the patient's feedback. And if he looks fine at 50, then I quickly increase it to 70 and increase it to 40 seconds. My normal lesioning temperatures are 70 degrees centigrade, never go beyond 70 degrees centigrade. 30 to 40 seconds, depending on what's going, in sometimes I can stop at 30, sometimes go to 40. This is the first step. Second step is, especially when you do palliatotomy, many people, because the tone comes down suddenly, they have a subjective feeling of weakness of one side of the body, though the motor power itself is okay. So in that situation, you just tell them wait for 3 or 4 weeks and sort of the tone normalizes and they get better. But if you do, I've had only one patient who actually had a COVID 2 weeks after surgery and then developed a small infarct from which he got better, post COVID. But that is about 2 months after surgery. But otherwise, I've really not had, touch wood right now so far, result that's happened. Professor Tara clearly says that if you target, if you lesion beyond 70 degrees, the risks are higher, because then, the popping happens, the blood vessels get damaged, which is why he says do multiple lesions to get a larger eventual lesion rather than one large lesion. And that's what we follow. So if you know the electrode holder has 3 holes. So we do multiple lesions. So each track you do 0, -3, -5 with a 1x4 electrode. So either 2 lesions or 3 lesions based on that. And that's when you get a reasonably larger lesion, 8 millimeter high, about 4 millimeter wide. And that way you sort of get away.
Thank you very much.
Welcome.
Thank you very much. Thanks to Professor Srinivasan and Professor Krishna Kumar for this wonderful session. Now it's time to move on to the second session, and before that I would like to inform our viewers that this webinar is broadcast on YouTube, WeChat and Zoom, and as of now we have around 730 people who have joined us live from all around the globe. So we'll move on to the second session, and I would like to invite Professor Yoichi Morofuji to say a short introduction and invite Professor Kiao for his lecture.
Okay, thank you, Roger. So let's move on the second lecture. It's a great honor for me to chair this session. I'm Dr. Morofuji from Nagasaki University, Japan. Today's second talk, we have Professor Kiao Zhu from Neurovascular Center, Shanghai Hospital, Naval Medical University in China. According to the CV, professor has a lot of honors and awards, and I feel he is one of the rising stars in Shanghai Hospital. Today, Professor Kiao Zhu is going to talk to us about stent treatment for acute ruptured aneurysm. In Japan, we cannot officially use stent for ruptured aneurysms in acute stage because of an insurance system, you may know. So I'm happy to learn a lot from this lecture. I'm sure Professor Kiao Zhu will present his wide experience about his endovascular techniques. Could you start your lecture, Professor?
Yeah, Professor. Distinguished Professor Morofuji and all the professors and experts online. I'm Dr. Zuo Qiao from Shanghai Hospital and from Professor Liu Jianmin's team. My major clinical and research direction is the endovascular treatment of subarachnoid hemorrhage and the ruptured aneurysms. And today I'm very honored to join in the ACNS webinar and discuss about the stent treatment for acutely ruptured intracranial aneurysms. And this is my disclosure. Since the ISAT trial, endovascular treatment has been the preferred therapy for the ruptured aneurysms. At the very beginning, stent treatment was only used for those very difficult and very complex aneurysms, which were difficult for either coiling or surgical clipping, such as the BBA, the dissecting aneurysms, fusiform aneurysms, and so on. In China, you can see the first case of stent assist treatment of a ruptured dissecting aneurysm was done by my tutor, Professor Liu Jianmin, in 2000. And then we continuously explored in different types of aneurysms, different locations, with different techniques, and proved the feasibility of stent treatment for the ruptured aneurysms. But at the very early time, the complication rate of stent treatment in acute stage was very high. So in the AHA and ASA guidelines in 2012, the recommendation was only class 3, which means it was not effective and might be harmful. But my centers and other centers throughout the world were still trying really hard to find out the reasons and to make it safer. We summarized the first 11 years experience of stent treatment for ruptured aneurysms. This was a single-arm retrospective study with 211 patients to explore the preliminary safety and effectiveness, and it was the largest series at that time. The major findings show the clinical favorable outcome was 82.9%. The 1-year complete occlusion rate was 75.5%, and the immediate occlusion rate was 45.5%. However, we did observe a relatively high complication rate of 14.2%. So, and we also analyzed the risk factors related to the complications. And we found that the aneurysm location, including the MCA and the ACAM artery aneurysms, was correlated with significant higher complication rate, and also the immediate embolization degree and the post-operative heparin use were correlated with higher complication rate. So based on these findings, we improved our clinical workflow and the treatment strategy, and I will share the details later. And then we started a new prospective case control study for 3 years. We enrolled 133 patients with ruptured aneurysms of stent treatment versus 289 patients of regular coiling to prove the safety and effectiveness further. And our results showed the stent treatment had a similar clinical favorable outcome, similar immediate occlusion rate, higher follow-up occlusion rate, and a lower recurrence rate compared to coiling alone. Even more, relatively complex aneurysms were enrolled in the stent treatment group. For safety concerns, the results showed a decreasing of overall complication rate compared to the previous study from 14.2% to 8.3%. And the stent treatment had a numerical higher complication rate compared to the coiling alone, but without statistical difference. So these results indicated that stent treatment was a safe and effective option for selective ruptured aneurysms. In Chinese guidelines, now it reads the stent assist coiling can be considered for ruptured aneurysms, which cannot be embolized by coiling alone. And we did a non-official survey and found that the stent treatment of ruptured aneurysms has been a common practice in China, with an estimate proportion of 30%. So around the world since 2017, more and more studies of stent treatment for ruptured aneurysms have been reported. So we performed a meta-analysis, enrolled 8 cohort studies. The results showed that stent treatment had a favorable effectiveness, but the complication rate was still higher than coiling alone. And we noticed that the results varied in different centers around the world. So how to perform a safe and effective stent treatment for the ruptured aneurysms, from our perspectives, the first tip is to select patients very, very carefully. Here are our principles. First, we need always try to clip those aneurysms with large hematoma. Second, if a patient is indicated for EVD, we still always perform EVD before endovascular treatment. And third, always consider the double microcatheter technique and stage the stenting strategy for priority. When doing the stent treatment for ruptured aneurysms, we are always aware for bifurcation aneurysms using the stent is riskier, and it is relatively much safer for side wall aneurysms. So those are our concerns for the case selection in the acute stage. And stage stenting strategy was also discussed since 2017. So we reviewed 47 ruptured aneurysms in our center, which received the conventional coiling alone in acute phase and staged stenting after a mean time of 4.2 weeks. No bleeding occurred during the intervals. So we considered that staged stenting strategy is a safe and effective option. Then we further did a single-arm meta-analysis with 5 cohort studies and 143 acute ruptured aneurysms treated with staged stenting strategy. And the results showed that the staged stenting has very low complication rate and high complete occlusion rate and favorable clinical outcome at follow-up. And we were very excited to find that the hemorrhagic complication rate was 0 before the second stage stent placement. So it was proved again that the staged stenting was safe enough. Then we compared the staged stenting with 69 cases and the stent in acute stage with 138 cases with a radiologic follow-up of 13 months and clinical follow-up of 36 months. The results showed that the staged stenting strategy had a numerical lower complication rate compared to the stent placement in acute stage without statistical significance. So we considered staged stenting strategy seemed to be safer. For such a wide-necked aneurysm on the MC bifurcation, we always used the double microcatheter technique to embolize the aneurysm with a small neck remnant, but with definite rupture point occlusion. Then we performed the staged stenting with additional coils or not after 1 month for this patient. And now staged stenting strategy is a preferred choice in our center. And as you see in the latest AHA and ASA guidelines published this year, staged stenting strategy was firstly included, and the recommendation was class 2. The second aspect in our is about the conservative use of antithrombotic strategy when we do the stent treatment for the ruptured aneurysms, including anticoagulation and antiplatelet therapy. For anticoagulation, before the 2010, we used the systematic heparinization during the procedure and the low molecular weight heparin after the procedure for 3 days. But we were very worried about, the ischemic event at the early time. However, we found the post-procedure heparin was correlated with higher bleeding rate. So we canceled the post-procedure heparin use after 2010 and only reserved the systematic heparinization during the procedure. The present antiplatelet strategy in our center is low dosage teriflunomide with individual dual antiplatelet regimens adjusted by TEG. When we decided to perform stent placement, Terifabin is used immediately before stent deploying and is kept for 12 to 24 hours with terifabin, and then stopped terifabin. The maintenance dosage of aspirin and clopidogrel lasts for 6 weeks, and then changing into mono antiplatelet of aspirin. The TEG is regularly tested 3 days after antiplatelet administration for monitoring and adjusting the antiplatelet regimens. And as for the dosage of terifabin, we performed the study and compared regular dose versus half dose of terifabin because the regular dose is recommended for PCI. And we found that the half dose of terifabin had significantly lower intracranial hemorrhage rate and equivalent ischemic complication rate compared to standard dose group. So half dose terifabin is now the standard therapy in our center. Well, and the third aspect for safe and effective stent treatment for ruptured aneurysms is the technical consideration. The braided stent is preferred, and using the soft and modified coils for complete occlusion. And always remember that the semi-gelling technique is helpful. In our daily work, we feel that the braided stent has a better result. So we performed this study and published in Neurosurgery. We compared the LV stent assist coiling versus coiling alone and found the numerically higher immediate occlusion rate in the LV stent group very closely to get a statistical difference. And also we compared the LV braided stent and the laser cut stent for the SCC in 235 patients with the propensity score matching, and the results showed the braided stent had higher immediate occlusion rate of 64.1% compared to the laser cut stent, and with low overall complication rate and the hemorrhagic rate in the braided stent group. So we think that braided stent is better for the stent treatment of RA. So why we prefer braided stent? Because the braided stent has higher metal coverage, smaller cell, allowing smaller soft cell coils use, fully visible, better apposition, and better protection of the side branches. And then we considered whether modified coils were better. So we compared the Elvis stent with hydro coils versus Elvis stent with Bayer coils after the propensity score matching also. Interestingly, we found that no patient suffered with bleeding in the hydro coil group, which was much lower than the Bayer coil group. So these preliminary results indicated the potential advantage of modified coils in the stent treatment for the ruptured aneurysms. And as for the technique consideration, we always suggest the semi-gelling technique for the ruptured aneurysm embolization because it can facilitate the stent treatment for complex wide-necked aneurysm, and the immediate occlusion rate can reach to 77% as we reported. The reasons why we prefer semi-gelling technique, including better adjustment for the microcatheter, a lower rate of coil protrusion into stent, and better neck coverage. So just like this case of the MCA bifurcation ruptured aneurysm treatment, the semi-gelling technique has been the standard strategy in our center. As the time limitation, the flow diverter used in acute stage was not included in today's speech, but as a special braided stent, the flow diverter treatment in acute stage will still follows these similar principles as I just cited, and the FDA was mostly used for the BBA and ruptured dissecting aneurysms in our center. And after 20-year exploration, the safety and effectiveness of stent assist embolization are getting better and better. And it was become a common treatment method for ruptured aneurysms. As shown on this slide, the procedural complication rate was declined from 14.2 to 7.2% during the past 20 years in our center. So in the latest AHA and ASA guidelines this year, the recommendation of stent treatment in acutely ruptured aneurysms was class 2. And at 2012, it was class 3. So this is a very big progress of stent use in acute stage. However, there is still a lack of strong enough clinical evidence whether it can be pushed to class 1 recommendation in the future. So we dedicate ourselves to endovascular treatment and stent treatment in acutely ruptured aneurysms in the past decades. And we are very delighted that our results and evidence have been included in the latest Chinese and American guidelines. And the latest bibliometric analysis showed our team was also the most prolific team around the world in the field of stent treatment for ruptured aneurysms. In conclusion, to perform the stent treatment for ruptured aneurysms safely and effectively, we should be very careful of case selection, the conservative use of antithrombotic strategy, and the technical considerations. So in the future, the high-level evidence is still needed to validate the SAC for RIA, and the coated braided stent may be helpful to further improve the peri-procedural safety. Due to time limit, I did not cover the FD treatment, but we still need further evaluation of FD for the ruptured complex aneurysms. And thank these young doctors in our center for their great work. At last, on behalf of Professor Liu Jianming and our team, thank you again for giving me the opportunity to share our work and share the experience from China. And we sincerely invited Professor Tumukuji and other professors and all the experts to join the Ocean 2023 in October in Shanghai. And thank you again.
Thank you very much for your wonderful lecture. So you shared a nice review of the treatment strategy for the ruptured aneurysm at the acute stage, made from the experiments of your group. So we've learned a lot from your excellent lecture. So now we're open for discussion. Any questions and comments from audience or web?
Yes, we have a question from Dr. Rahman. Yes. Dr. Rahman.
Good evening. Thank you, Professor, for your nice deliberation. I have one question. You use anticoagulation during the procedure and you don't use after the procedure. But do you have any case when you have paraprocedural thrombosis during stent deployment? And in that case, do you continue anticoagulation even after the procedure?
Okay, thank you, Professor Rahman. For the ischemic events during the procedure, actually it is very, very common at the early time. Especially it is very common before we use the tirofiban. So before the 2010, we do not have the tirofiban. We just give the patient the aspirin and clopidogrel through the mouth or through the rectum. But at that time, the ischemic events was very high. After we have the tirofiban, frankly speaking, there's nearly zero ischemic event, during the stent use in the acute stage. So actually, we now more worried about the hemorrhagic event when we use the stent during the procedure. So you can see we have a lot of evaluation on different techniques, different materials or something. The core target for us is to lower the hemorrhagic event. Professor.
Thank you. But what if there is a ischemic event during procedure? Do you still continue anticoagulation post-procedure?
No. We do not use the coagulation during the surgery or after surgery. If we have the ischemic event during the procedure, we always use the terofibin through the vein, right? But if the event happened, we changed to use the terofibin through the artery. So we use a microcatheter, navigate the microcatheter into the stent near the thrombus and push some terofibin through the microcatheter to the thrombus. Most of the time, it can be solved. No anticoagulation anymore.
Thank you, Professor.
Thank you very much.
Thank you.
Well, if there are no further questions, we can invite comments from Professor Morofuji.
Okay, so you showed a nice recoiled MCA aneurysm case with stent assist technique. And so could you tell me the percentage of the rates of the clipping and the coiling?
Frankly speaking, we unless the patient with MCA rupture aneurysms with huge hematoma, we choose the clipping first. And if just MCA ruptured with not hematoma, 90%, we do the endovascular treatment.
So the 90% for 90% for MCA case.
Especially we use the strategy, the staged stenting strategy. It is very safe, very safe.
So the interval of the first stenting and the second stent assist coating is kind of the 4-week or 6-week interval.
4 to 6 weeks. Yeah. After 1 month.
After 1 month.
As soon as possible. Yeah.
So when I use kind of the staged cases, we usually try only 2 weeks, but you don't have any experience about the rupture between the interval.
Yeah, I think 2 weeks is okay because for most of the patients, for Hunt has 1, 2, 3 is okay. But for the Hunt has 3 or 4, because we need to help the patient to pass the spasm, right? The period. So always after more than 2 weeks. Yeah.
Okay. So another question is, you usually use a kind of double microcatheter technique. So even in a smaller aneurysm cases, the 5 millimeter, you use
no.
No. Okay.
No,
so it's kind of large cases.
Yeah. It's always for some big aneurysms or aneurysm with 2 sac or some very ugly aneurysms.
Okay. So another question. So you present one case of the blood blister type aneurysm, BBA aneurysm. So now at this moment, you usually use stent assist coating, or you use a flow diverter in the acute stage?
Flow diverter with coils in the acute stage.
So it's almost the same anti-thrombotic strategy?
Yeah.
Even in a flow diverter?
Yeah. So terofibin is very helpful.
Okay.
Yeah. Actually, there's no guidelines for the dosage of terofibin. So we may use more dosage for FD than the
Mm-hmm.
common
Oh,
stents.
yeah, I think so. I agree. Mm-hmm.
But just the individual experience.
Mm-hmm.
Yeah.
So actually, so in Japan, we cannot use tirofiban at this moment. What do you think? It's impossible to use flow diverter in acute stage.
So that's
unless
a
we
big
don't
problem.
have any
Yeah,
tirofiban.
yeah.
Uh-huh.
So maybe you can use the Tagarela instead of the clopidogrel. Yeah, maybe it's useful.
Okay, thank you.
Thank you very much. That was a very elaborate presentation and we learned a lot. But I would like to ask Professor Kiao that is the insurance system, does it support this strategy of yours in the country?
Yes.
It does. Okay.
We are allowed to use stent in the acute period.
That's very interesting.
Maybe it's very lucky for Chinese patients.
Yes.
I think so.
Yeah.
Well, in that case, we'll wind up this session as well. If there are no further questions, I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Sharan Srinivasan and Dr. Kiao Zhou, as well as the chairs, Professor Krishna Kumar and Professor Yoichi Morofuji, for the time and support for the ACNS webinars. Also, special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 730 people who have joined us from all around the globe. And a special thanks to my co-host Liu Bun Singh as well for joining me today. We will meet next week, next Saturday. Until then, it is bye-bye from all of us. Thank you very much for joining.